Thank you, Kapil. So, what we'll do is now we'll look at some cases on acute facial trauma. Right. So, the panel is here, and I think everybody is sufficiently awake. So, a 9-year-old male with a 5 days old injury, we've talked about this ad nauseum, but still, it would be good to reinforce. So how are you going to manage? So this is a 9-year-old boy. He's got an injury which is about 5 days old. Kapil, what would you do? There's a mic.
So
what type is it, and would you reduce it or you would leave it alone, or what would you do?
yeah, so there seems to be angulation at the distal radius. So I think at 5 days one would attempt a gentle close reduction.
Okay. So you would attempt a gentle close reduction. Doctor?
Can we have another view?
Another view is not there. This is the relevant view, the lateral one.
So I think it's normal in APV. So it's a type 1 injury. It's a little bit angulation. 5 days old is not a...
Do you think it's a type 1?
Type 2 injury. But 5 days is not that much old. For at least 1 week we can try.
Up to a week you feel you should try.
Yeah.
Suppose you do a gentle close reduction and it doesn't come. You will open it or you will try? How many times you will try?
I will not certainly open it.
No open reduction. Anybody for open Carly? 5 days, what would your approach at Boston be? Can we have a mic here? Mic do to kare pule. Okay. So if you are doing a close reduction, what would your maneuver be? Would you exaggerate and traction, or you would push? What do you do at 5 days?
So for these fascial injuries, I don't do the very gross exaggeration, but I do sort of try and bring it back a little bit and then pull it out in traction and bring it over the top.
Yeah,
it's just not quite as dramatic as the metaphyseal ones.
Correct. So but the essential principle in facial injury for reduction has to be traction and not trying to push it because it crushes. That is okay in metaphyseal. That's I think the key message here. There was an AP view, sorry, I had hidden it. So that's for you. So this was 5 days old, and your options were close reduction pinning, open reduction pinning. ARS, can we have an ARS? Percutaneous technique. Would you lever it with a K-wire or something, or you would leave it alone and it will remodel? What does the audience feel? अलग म्यूजिक है आज. All right, so 49% close reduction pinning, 32% percutaneous. So people would try percutaneous, and small percent, that 5 I don't know. People right. Okay, so what was done was a reduction technique at 5 days and pinning. Is this acceptable? Would you accept this? This was 5 days old. Surgeon wasn't getting a perfect reduction. This is the best that could be achieved. Is this okay? Not okay? Would you have, if it was not coming adequately, would you have not put the pins, left it alone with a plaster? Alric? It's okay. Looks decent. Okay, so this was an acceptable reduction, and eventually looked quite decent. Right. So is that okay, Kali? Are you happy with that position at about say 6 weeks? Pins are out at 3 weeks.
So I think the position's fine. I'm a little worried about the growth plate though.
Yeah, you are worried about, but you think the growth plate worry is because of the surgery or the injury or the delay, the 5 days?
I think that it is not likely to be the injury.
Okay.
It's much more likely to be either the manipulation or potentially multiple pins.
Multiple pins. So, like Kali's pointed out, a late presentation, forceful reduction, the maneuvering, or too many pins. could be the problem. Sometimes it's the injury, or Salter type 2 usually doesn't cause growth arrest. 4% only. So would you be happier leaving it alone if you don't get a satisfactory reduction rather than struggling?
I would never force a IFICS, and if
So it was a 5-day-old, you tried to do the reduction and you didn't really get a perfect reduction. Would you put a cast rather than pinning it, or you would do what was done?
So if it didn't move at all, I would just put a cast on.
It did move, you saw that there was a partial reduction.
So if I can get a partial reduction, I'll put a single pin.
Single pin,
To
okay.
stop it from
So that's an important message. So too many pins is an issue. Too many attempts is an issue. And the way you do it is also an issue. So you should be aware of that. And this is what happened next. As pointed out by Carly, over a period of time. So can you identify what's happening? There is a physeal bar, the ulna is overgrown and the hand is developing a deformity. So things did go wrong in this situation. So another situation, 8-year-old with a forearm injury with a similar sort of a fracture in a cast. Would you accept this? This comes to you at 5-7 days. Or you would, now it was same, 5 days. Would you do a surgery, get a reduction, or leave it alone? Leave it alone. So looking at the earlier one, we become wiser, right? And this was left alone. This is at 3 weeks. It looked bad at 3 weeks. And the question was, should you correct it or no? And 3 months later, you can see how nicely it remodeled with full function. So the message here is, how many attempts does one make at reduction, especially when physeal injuries come up in 3 to 5 days, literally, in younger kids? A week or above, trying to manipulate is not such a good idea. Repeated efforts at reduction do nothing more than grade the plate away. These injuries unite quickly, so attempts at correcting a malposition after 1 week are liable to do more damage than any good. Written by Rang in 1983, right? Long ago. The second issue was the pins. So Carly said a single pin, and this, as you see, was fixed with a pin, and 2 years later there is an arrest there. So the question arises, all of us pins, can I have a show of hands, how many of you pin a lower end radius physeal injury? All of us do it, and this pin is demonstrating a growth arrest. So do pins really cause growth arrest? That's the moot question. And what does literature have to say about it? And it's pretty unclear. Between 1965 to 1975, Muller pinned all lower end radius fractures and did not find a single growth arrest, which is pretty long time. A paper from Horai said that if you use large diameter pins, he had 3 cases with arrest. So maybe the diameter of the pin has something to do with the arrest, and repeated attempts. So too many attempts at trying to pass to get a reduction and a perfect pinning position. Remember, a metaphyseal injury is different. A physeal injury can cause problems. Don't try to put too many attempts and too many pins. The group from Boston did this study, Min Cocker and I think from Peter Waters' group again, long time ago. They tried to study the effect of pinning across the physes, and they did an MRI evaluation. 11 patients were followed at 3 weeks and 6 weeks, but they did not find any evidence of growth arrest in this. But the flip side was they did not consider threaded pins, the duration of pin placement, or attempts in this study. They just found that a pin per se did not cause growth arrest on an MRI. So what causes growth arrest? Probably large diameter pins, probably leaving them in for too long, maybe threaded pins because they damage the physes as they pass. Titanium pins, probably they evoke a more osteoblastic response. Multiple pins, multiple attempts, and maybe non-perpendicular pins. So please remember to avoid all these. And probably when you are pinning, you won't get a growth arrest. When you are passing the pins, avoid the perichondrial ring, which Kapil has pointed out. Be as longitudinal as possible. Remain in the place for as short a period of time as possible. Don't leave a K-wire in the physes for more than 2 to 3 weeks. Get it out because it gums up immediately. Use a very thin diameter. Use a low torque tool. I even pass a K-wire on a T-handle by maneuvering by hand rather than a drill. Don't use your high-speed drills or high velocity drills. You could use the intrafocal method occasionally. You could slide along the epiphysis in the center an intrafocal pin without actually going across the physis. So there is one more way of doing things. And biodegradable pins, what is the status? Most of the papers are from Finland, and what essentially they said was biodegradable pins usually are not stable enough. They displace or break, and we fortunately in India have no access to them, so we can forget about it. Another example of an acute injury, a 10-year-old boy, this is the injury, right? Salter Harris 4, I would say. And how would you tackle this? So this is what was done, just to highlight. Is this acceptable? What's wrong with it, Negi sir? Horizontal. One is you could have an intraepiphyseal screw. Reduction doesn't seem to be good. And lastly, the pin was left in, and this is what happened. So an example to show you, if you just leave the pin in for too long, what can happen? The pins, if they are going across physes, need to come out immediately. Another example, a Salter Harris 4. Would you accept this or operate? How many for surgery? Yeah, most of them. So this is a type 4 crushing injury. You may have a large amount of problems, but you have to get the articular alignment perfect. And what is recommended is screws across the physes and metaphyses don't violate the epiphyseal plate, and you could do an arthrogram to confirm articular congruity, and that is how it should be done. That's at 6 months. Comminuted type 4 intra-articular with a physeal, again you could do a percutaneous reduction, aspiration of the hematoma, an arthrogram, placement of a transverse K-wire and a cannulated screw on it. And this can be achieved very nicely just through a small incision like that. Sometimes you have interposed periosteum. I am sure the ankle session will cover more of this, so I won't. You may have to open if you believe there is periosteal interposition. And then again, just to highlight the metaphyseal, if you have a Thurston Holland beak which is large enough, use a compression screw. Across the epiphysis, use a smooth pin, but the pin has to come out as early as possible. So don't leave the pins in for long, the screws could remain, right? And that's his function. So you can do K-wire assisted methods, put screws, put wires, but be aware of how to put the screws and how to put the wires. Example again of acute injury where you use small diameter pins. So display Salter Harris 3-4, you can remove the interposed tissue if required, and take care of the soft tissues, smooth pins across the physes, screw thread should not cross physes, and use small cannulated systems. Okay, don't do disasters like this. A middle third radius which has been K-wired from across the physes, right? So I'll stop here and I'll invite Hitesh to talk about chronic or principles of late presenting physeal injury. Thank you.